again, brief hepatitis, the rest of hepatitis infections. D is fairly rare. It needs the hepatitis B for replication. So if patient doesn't have B, there is no way to develop hepatitis D. E is another type of hepatitis. It's virtually unknown in United States, although with influx of immigration this may be increasing, but it's another hepatitis with fecal oral transmission. And G is one of the newest hepatitis, and it's parenteral and sexually transmitted route. Major piece of information I want you to remember from this slide, it's about hepatitis D, that D needs hepatitis B for replication. That's a common question I would ask probably, or elsewhere you'll be asked. But a patient cannot have hepatitis B without hepatitis B. So D needs B. In general, when hepatitis infection occurs, this following sequence take place. They will have incubation phase, which is different from different types, prodromal, pre-icteric phase when patient turns jaundice, before patient turns jaundice, and icteric phase when patient develops jaundice, and recovery phase. If patient is having chronic hepatitis B or C, they may not even get into icteric phase because icteric phase is very remarkable in hepatitis A, and usually there are some lucky people who had infections with B and C, and they were able to recover themselves without any drugs. If they don't recover B and C, they will slip into phase of chronic hepatitis and gradual deterioration of the liver. Fulminant hepatitis appears from one or the other cause when the hepatocytes getting impaired and necrotic, and also acute liver failure can result from Tylenol overdose, getting more and more serious nowadays, the Tylenol overdose. The recent one I learned was buying sleep aids, Benadryl based, like NyQuil, or not NyQuil, I'm sorry, Benadryl PM, or Tylenol PM, and taking it because the sedative qualities of it, and overdosing on Tylenol as an additional drug, although drug seeker is looking for Benadryl sedative qualities. But again, can be suicidal attempt to have acetamin overdose, and this is a true liver emergency. And I know the whole lecture today was about emergencies and true emergencies, but this is one of the worst situation you can deal if a patient presents with acute hepatic failure and acetaminophen overdose. This most of the time requires liver transplant, and because liver will have very small chances to recover. However, some patients may recover and overcome the acetamin overdose. But again, it's a true emergency. If you are facing something like this with your patients, this is need to be addressed with the closest transplant clinic, and patient needs to be maybe given transplant liver if they are candidate and if they meet all the criteria. This is different whole ball game. I don't want to go in there, but what you need to take from here, acetamin overdose will result in acute hepatic failure, which may require liver transplant. Cirrhosis is the disruption of liver function and structure. The function of liver is lost, and liver tissue will turn into nodular and then fibrotic, and fibrosis there will be less and less biliary channels, and liver becoming more and more obstructed and will cause portal hypertension. Because of that, blood doesn't go to the places in liver where it usually goes, so it also adds, fibrosis adds to developing the necrosis. So cirrhosis is a sequela of either hepatitis or alcohol-induced hepatitis, but in cirrhosis is not reversible. Even patient, let's say, stop drinking, but we still will have cirrhosis, so liver function is lost. Cirrhosis brings lots of other different issues of portal hypertension, like we talked, and also a different other problems such as biliary obstruction, jaundice, ascites, and hepatic encephalopathy. But overall, patient will have liver failure and death secondary to that. A patient with cirrhosis may be candidates for the transplant, and unfortunately, patient needs to be abstaining from alcohol or any other illicit substances for 6 months to be considered a candidate, and most of the time, or not most of the time, but sometime patient just will continue using alcohol and illicit substances and will not be qualified as transplant recipient. So cirrhosis can be alcoholic, because alcohol puts lots of taxing on the liver. Alcohol damages hepatocytes. Every time you drink alcohol, you cause some damage to your liver. So avoiding alcohol completely is maybe the best thing you can do for your liver, but drinking shouldn't be excessive by no means. Binge drinking especially can cause severe damage. Of course, this may result in damage of hepatocyte. After ingestion alcohol, everybody will have somewhat elevated liver enzymes, although cirrhotic liver does not have elevated liver enzyme because most of the hepatocytes are damaged, so there is nothing much to damage. So biliary cirrhosis, this is a different disease where cirrhosis will start in bile ducts, and it's actually called primary biliary cirrhosis. It's autoimmune disorder, and there are ways to treat it with medication that will work on the immunity itself, versus secondary biliary cirrhosis, secondary to obstruction. In this point, alcoholic disease is definitely much more common than biliary disease. Post-necrotic is the consequence of chronic disease, again losing blood supply to the liver and getting less and less blood supply and necrotizing the liver. The last slide I'd like to talk is disorder of pancreas and disorder of pancreas as pancreatitis. So two major causes of pancreatitis. There can be, first of all, can be autoimmune pancreatitis, but it's not common. But two major causes: alcohol and gallstone or cholelithasis. What happened in both cases, both of the substances will cause injury to pancreatic cells and duct, and leakage will occur of the enzyme into pancreatic tissue, and having self-digestion of the pancreas, and then leaking into blood vessels and causing damage locally into other organs. But this, at this point, I want you to know these two sources. Alcohol as a toxic substance to pancreatic cells and duct. And if alcohol has an influx somehow into pancreatic ducts, it will cause destruction right there. When we're having cholelithasis, small stones, small gallstones can go upward through the pancreatic duct and actually cause blockage and cause severe pancreatitis. In that case, ERCP may be recommended to remove the duct obstruction and just to release the inflammation of the pancreas. And the after that, patient will have marked improvement within hours if the release is done, and if the obstruction and pancreatitis is secondary to biliary stone. Alcohol-related, the treatment will include MPO status, so not to encourage pancreas to produce any digestive enzymes, and also hydration, and most of the time. Also, patient has to be consulted heavily about alcoholism and consequence of pancreatitis. Although sometime you would see when patients come with alcohol-related pancreatitis, I had several people who had quit drinking after third or fourth recurring pancreatitis attack, and they finally made that correlation between alcohol and pancreas. And I can only imagine how hard it was to do that, but dealing with pain and hospitalization every time is also very difficult. And patient, talking about pain, patient also will require pain management while they are hospitalized. There are other sources, obstructive sources, like dysfunction of sphincter of Oddi, but at this point for this course I want to limit our conversation to this, and this will conclude our lecture. Thank you very much, and call me and email me if you have any questions. Have a great day.